Fellow Medicos, good day to all of you. This is Dr. BK for you, and today I am going to discuss about one of the most important topic or the most important structure in our human body, and that is the heart. So in today's session I will be discussing about the external features of the heart. So from the outside, what are all the structures we can appreciate about the heart, how actually the heart appears, and how the chambers of the heart we can identify, and how actually they are situated. So our learning objectives for today, I will give a brief introduction about the heart, followed by that where actually it is situated. So the situation and the position of the heart, then the presenting parts, the various parts, then the various surfaces and the borders of the heart. Now, you all know that heart is a muscular organ. It is conical in shape and it is very much dispensable, inevitable or indispensable for the human life. You all would have come across the heart during your school days, in your textbooks or pictures or the school laboratories, museum and so on at various places. Basically, if you look at the heart, it is about the size of one's own fist. Okay, and we call it as a muscular organ because it pumps the blood to the different parts of the body. So mainly the main structure is that heart muscle, which is very vital for the functioning of the heart. Okay, now the heart is actually situated in the middle mediastinum. So we have seen extensively about what is the mediastinum, what are the boundaries of the mediastinum, the subdivisions, and what are all the structures present. So heart with its covering, that is the fibrous pericardium, is actually present, or the heart is situated in the middle mediastinum, that is in between the two lungs and the pleura covering it. Okay, so anteriorly you can tell it is present between the second to sixth rib, and posteriorly it is from the fifth to eighth thoracic vertebrae. So when you look at the heart from the front, it appears like this. Not all the four chambers you will be able to appreciate at once, as it is depicted in some books. Okay, so mainly from the ventral surface you see this vast area which is visible to us from the anterior is the right ventricle. So mainly the right ventricle is seen anteriorly. The next structure you see is part of the left ventricle. Okay, even this won't be visible only if we retract the lungs. If you just retract the lungs, only then you will be able to see a part of the left ventricle. Or if you remove both the lungs, then you can see part of left ventricle, then left auricle and part of right atrium, and a very small left auricle. Okay, so these are the parts mainly you come across. Okay, then the heart weighs around 250 to 300 grams plus or minus 50 grams. It might vary between person to person and also between the males and females. Female heart is slightly weighs lower in weight as compared to the male heart. So both I am telling as the adult heart. Okay. Then it is 4 chambered, as you all know. The 2 chambers, upper chambers, which are actually not exactly upper chambers, they are somewhat situated posterior superiorly on the 2 atria, the right and the left atria. Atria is plural, atrium is singular. Then we have the 2 ventricles, the right and the left ventricles. Okay, both the atria are separated from each other by a septum, which is actually called as the interatrial septum. Both the ventricles are again separated by a septum, which is actually called as the interventricular septum. On the surface, the place or the position of the septum is represented by a groove, and this is well appreciated in case of the ventricles than the atrium. In the atrium, you won't be able to visualize the groove anteriorly or externally, especially from the front. Posteriorly, you can see a faint septum, faint groove externally. Internally, there is a very well developed septum between the atria and the ventricle. Externally, between the atria and ventricle, you also see a groove, the atrioventricular groove. Okay, so that is actually called as the atrioventricular groove or the sulcus. The right part of the heart mainly deals with the deoxygenated blood, whereas the left part of the heart deals with the oxygenated blood. Okay, venous blood is mainly present in the right chambers. From the right atria, it goes to the right ventricle. Then from there, it goes to the lung via the pulmonary trunk. Then from there, through the pulmonary veins, the blood enters into the left atrium, and from there, from the left atrium, it enters into the left ventricle. From the left ventricle, it is pumped to the various parts of the body through the aorta. Now, interiorly, there is a communication between the atrium and the ventricle. They are called as the atrioventricular orifice, and they are guarded by a valves. Right atrioventricular valve is called as the tricuspid valve. Left atrioventricular valve is actually called as the bicuspid valve. So the main function of the valve is to prevent the regurgitation of the blood or the reverse flow. From the ventricles, the blood should not enter into the atrium. So that is the main reason why these valves are actually present. Okay. So as I told you, interatrial septum between the 2 atria, anteriorly it is not possible to actually locate this interatrial groove externally. That is the representation of the septum externally is the groove. Interventricular septum is represented by the groove anteriorly. Anterior part of interventricular groove you can see. Posteriorly also you can see the posterior part of interventricular groove, and posteriorly interatrial septum is represented by a faint groove, interatrial groove or sulcus. Between the atrium and the ventricle, you see the atrioventricular groove. So that also posteriorly is very much marked, and it is also called as the coronary sulcus. Okay. Whereas anteriorly that atrioventricular sulcus is not complete because it is marked or interrupted by the infundibulum or the outflow part of the right ventricle here. Okay. Then if you look from the heart from the behind, now you are able to visualize the left atrium which was hidden from your view anteriorly. Okay. Left atrium is most visualized from the posterior aspect, and also you can see the left ventricle also Major part of the left ventricle is also seen posteriorly. So with this short introduction, I will directly move on to the parts of the heart. The heart has got an apex. Anteriorly it can be seen. Then it has got a base, which is seen mostly on the posterior aspect. Base cannot be viewed from the anterior aspect. Then it has got the anterior part which you are viewing extensively. This is called as the sternocostal surface. Then this lower part posteriorly is the diaphragmatic surface or the inferior surface. Then you have a left surface, left lateral surface. There are also three borders. One is called as the right border. Then you have the inferior border and an ill-defined left border. Okay, this is the right border, inferior border, and then we have an ill-defined left border. Okay, so now let us try to actually discuss and understand each and every part of this surface and the borders one by one. So first is the apex. Apex is that part of the heart which is conical or pointed, you can tell, and it is directed upwards, forwards and towards the left. It is present in the fifth intercostal space. Okay, sorry, downwards, forwards and left. It is present in the fifth intercostal space, medial to the mid-clavicular line. So that will be the middle of the clavicle. You draw a straight line, that is called the medial mid-clavicular line. Just medial to it, you can locate the apex in the left fifth intercostal space, or it is 9 centimeters from the mid-sternal line. It is 9 centimeters from the mid-sternal line, or just medial to the mid-clavicular line, just medial to the nipple. But the nipple is actually a non-reliable landmark. You cannot rely on the nipple because the nipple position varies considerably, not negligible. There is a considerable variation of nipple from person to person and especially in the females. Okay. Now, the apex is mainly formed only by the left ventricle. Okay. It is formed only by the left ventricle, and the apex beat, when you put a step and you hear a sound there on the left fifth intercostal space, what you auscultate is the apex beat, which is the forward thrust felt on that left intercostal space, left fifth intercostal space during the ventricular systole. That means during the contraction of the ventricle, you call it as ventricular systole. You feel that forward thrust or push on the left fifth intercostal space is actually called as the apex beat. And apex is that part of the heart which is the most movable part. Okay, it is the most mobile part. Next, what we see is the base of the heart. The base of the heart is actually situated posteriorly. It is situated posteriorly and mainly formed only by the atrium. And that too, majority or 2/3 of it is mainly formed by the left atrium, and 1/3 is actually contributed by the right atrium. It is placed posteriorly and it is also a fixed part of the heart. Okay, so it is resting on certain structures. I will just enumerate these structures. Roughly quadrilateral in outline or quadrangular, square. It is actually four-sided, quadrangular in outline, and as I told you, it is 2/3 contribution is from the left atrium and a small part is by the right atrium. Now what are the boundaries? The base actually extends from the 5th to 8th thoracic vertebra in recumbent position, whereas in standing position what happens is it just descends one vertebral level below. That means from the T6 to T9, one level below in erect posture. Okay. Same way I told you about the apex of the heart, which is situated in the fifth intercostal space. In children, it lies at the level of 4th intercostal space. So one space above. It is still not descended to its final adult position in the children. The boundaries of the base of the heart, above it is the bifurcation of the pulmonary trunk. Okay, it is the bifurcation of the pulmonary trunk. Below it is separated from the ventricles by the coronary sulcus or the atrioventricular sulcus or groove, which is called as the coronary sulcus because it lodges the coronary sinus, the venous channel draining the heart. Okay, so below it is limited by the coronary sinus. Now this is the base which we have been describing, mainly formed by the posterior surface, whereas the clinical base corresponds to the upper border of the heart, where you hear the aortic sound on the right second costochondral junction to the left second costochondral junction, the pulmonary sound. If you draw a line between the two auscultatory sound of aortic and pulmonary, and that forms the clinical base of the heart. So the posterior relations, the base actually is related to or rests on these structures, mainly the posterior mediastinal structures. Immediately behind the base you have a space, the oblique sinus, which is present between the heart and the fibrous pericardium. It is not actually the heart but is the serous pericardium, and between the two layers of the serous pericardium the oblique sinus is present. We have discussed about this extensively, so I am not going to discuss much on this in this session. So oblique sinus is present immediately related to the base. Then you have the fibrous pericardium. External to the fibrous pericardium you have the bifurcation of the trachea. Then you have the esophagus and descending thoracic aorta. Actually it has been removed to show these structures. Descending thoracic aorta. Thoracic duct you can see, especially in the upper part, not in the lower part. Upper part you see the thoracic duct. Then this is mostly the left mediastinal view you are seeing. On the right side you will also see the azygos vein. Then some sympathetic nerves, planktonic nerves. All these are actually related to the base of the heart. Okay, so esophagus, thoracic duct, descending thoracic aorta, and sympathetic chain, and also all these are separated by the pulmonary veins. Okay, the left pair and the right pair actually crosses from the right lung and then enters into the left atrium. So the right and left pair of pulmonary veins, they are all related to the posterior aspect. Now if at all there is a mitral valve stenosis, if the valve is not functioning properly or it is stenosed, then blood does not empty properly from the left atrium. Okay, so there will be an emptying defect. So naturally what happens is there will be a dilatation of the left atrium, and this might compress your esophagus, resulting in difficulty in swallowing or dysphagia. So that is mainly seen in the Ortner's syndrome. So in mitral valve stenosis, there will be the dilatation of the left atrium, followed by which it will compress your esophagus, resulting in dysphagia. Okay, so that is about the base of the heart. Now let us see some features on the sternocostal surface. So now what you are seeing in this picture is the sternocostal surface or the anterior surface of the heart. It is mainly formed by the right ventricle. It is mainly formed by the right ventricle. Then you also see a part of left ventricle, right auricle, and very minimal part, small appendage you see here is the left auricle. It's almost hidden from your view. Only a very small part of it you can visualize. Mainly you come across is the area is mainly occupied by the right ventricle. 2/3, 1/3 is by the left ventricle, and part of the right auricle you see here. So auricle is that ear-like appendage of the atria, the right and the left auricle. Now, what are the features on the sternocostal surface are, between the atria and the ventricle you see the atrioventricular groove or the sulcus. Okay. On the right side you see right part of atrioventricular sulcus anteriorly. This is anterior part of the groove you are seeing, which lodges the trunk of right coronary artery. In the atrioventricular groove you see the right coronary artery along with a small cardiac vein. Then mainly you see between the two ventricles the anterior part of interventricular groove. Okay. So first is the atrioventricular groove, which I have described, which contains the right coronary artery and the small cardiac vein. Next is the anterior part of interventricular groove, or called as anterior interventricular groove, which contains the anterior interventricular branch of left coronary artery and the great cardiac vein. So these two things mainly you come across in the sternocostal surface. Okay. Then the sternocostal surface is mostly covered by the anterior border of the lungs, right and left lung, and with its covering, that is the pleura. Okay, so the anterior border of the lung and the pleura covers the sternocostal surface. Thereby, what happens is, this anterior border of lung and pleura intervenes between the heart with its pericardial covering and the anterior thoracic wall. So it is actually related to the anterior border of both the lungs, right and left lung, and the pleura. External to that you have the anterior thoracic wall, that is the 2nd to 6th intercostal space with its muscles and vessels and nerves. Okay. But on the left side, between the 4th to 6th, okay, between the 4th to 6th rib, the left lung deviates laterally, forming the cardiac notch. Deviates laterally, forming the cardiac notch. Thereby, since it is not, that area is not covered by the lung and the pleura, and it is directly related to the anterior thoracic wall, and that is actually called as the area of cardiac dullness. Okay. So the area of cardiac dullness is that part of the heart. Which part of the heart? Especially is the right ventricle, which is not covered by the anterior border of the lung, especially the left lung, because it is the left lung which deviates laterally between the 4th and 6th rib, and that is called as the area of cardiac dullness. So we have seen about the sternocostal surface. Now moving on to the diaphragmatic surface. So the diaphragmatic surface, it is also called as the inferior surface and mainly formed only by the ventricles. Base is formed only by the atrium. We have seen that base mainly atria, only atria forms it. Here only ventricles form the diaphragmatic surface. It is somewhat flattened, or you can tell simply it is flat. Okay, and it is the inferior surface. Diaphragmatic surface is actually the inferior surface, directed backwards, downwards, and it is mainly formed only by the ventricles, 2/3 by the left ventricle and 1/3 by the right ventricle. Okay, 2/3 by the left ventricle and 1/3 by the right ventricle. The features on the diaphragmatic surface, you see the posterior part of interventricular groove. You see the posterior part of the interventricular groove. This is called as posterior interventricular groove, which lodges the posterior interventricular artery and the middle cardiac vein. These two structures, posterior interventricular artery and the middle cardiac vein. You see that. Then it is separated from the base of the heart by the posterior part of the atrioventricular groove. The posterior part of atrioventricular groove, again you are able to see the left side as well as the right side. Left side, again you are able to see the great cardiac, the coronary sinus lodged in here. That is why it is actually called as the coronary sulcus. The left part of AV groove, you have the coronary sinus along with the left circumflex artery. Here right part of groove, the trunk of right coronary artery continues. So mainly on the posterior interventricular groove containing the posterior interventricular artery with the middle cardiac vein, which I told you. Next is the coronary sulcus, separated from the base by the coronary sulcus. What is actually the crux of the heart? So here in this area, what you see is the crux of the heart. It is the meeting point of interatrial groove, then posterior part of interventricular groove, and right and left half of atrioventricular groove. Okay, interatrial, posterior part of interventricular, and right and left part of atrioventricular groove. The meeting point of that area is actually called as the crux of the heart. So that is about the diaphragmatic surface. Now this surface is related to the central tendon of the diaphragm, and below the central tendon of diaphragm, it is related to the left lobe of liver and the fundus of stomach. A little bit of fundus of stomach you are seeing here. Of course the liver has been removed. So the inferior surface rests on the central tendon of diaphragm, and below that we have the left lobe of liver and the fundus of stomach. Next we will come to the left surface of the heart. Now the left surface of the heart is mainly formed, that circled area what you are seeing is the left surface, is mainly formed by the left auricle and the left ventricle. Left auricle and the left ventricle forms the left surface of the heart. Left part of atrioventricular groove, you are able to see that, which lodges the trunk of left coronary artery, and immediately it is dividing into left circumflex and anterior interventricular. So left circumflex artery. In the sulcus, what is present is the trunk of left coronary and then the left circumflex artery. Anterior interventricular is seen in the anterior interventricular groove. So that is your left part of AV groove lodging the left circumflex artery. Then relations of this left surface, it is related to the left lung and the pleura. The pleura is the mediastinal pleura. So it is this surface which makes impression, cardiac impression of the left lung, part of left auricle, left ventricle, and also a part of right ventricle also makes an impression of the left lung, cardiac impression. Now between the pericardium and the mediastinal pleura, you have the phrenic nerve and the pericardiophrenik vessels. Phrenic nerve and the pericardiophrenik vessels intervening between this left surface covered by pericardium and the mediastinal surface of left lung covered by the mediastinal pleura. That is about the left surface of the heart. So we have finished with the apex, base, and then the diaphragmatic surface, sternocostal surface, and the left surface of the heart. Now we will proceed to the borders of the heart. The first border which we are going to see is the right border of the heart. So the right border is mainly formed only by the right atrium. It is convexity towards the right and extends from the opening of the superior vena cava to the opening of the inferior vena cava. Okay. So extension is from the opening of superior vena cava to the opening of the inferior vena cava. Right border. The right border separates the sternocostal surface from the base which is present behind. The right border separates the sternocostal surface from the base of the heart. Now, along the right border, you will be able to see a faint sulcus which is called as the sulcus terminalis. Along, corresponding to the right border, you see a sulcus which is actually called as the sulcus terminalis. Okay, interior, on the interior aspect if you look, it is represented by a raised margin which is called as the crista terminalis. So the interior crista terminalis is represented as a sulcus on the external surface of the right atrium, that is along the right border. The crista terminalis separates the interior of the right atrium into an anterior rough part and the posterior smooth part. Okay, so let us not discuss much about this. We will discuss that when we come to the chambers of the heart. Okay. Let us just concentrate only on the external aspects. So along the right border, you see the sulcus terminalis. So it will be related, again covered by the pericardium. Outside the pericardium to the right lung and the pleura, mediastinal pleura, and then phrenic nerve and pericardiophrenik vessels. So what are all the relations which we have mentioned for the left surface? The same thing you have to write for the right border. Only thing you have to change is there what all comes as left, here you make it as right. There it was right lung and pleura, here you write as, there it was left lung and pleura, here you write it as right lung and pleura. There left phrenic nerve and pericardiophrenik vessels, here right phrenic nerve and pericardiophrenik vessels. So relations of the right border. The next border is the inferior border. It is again a rounded border, almost semicircular. It extends from the opening of the inferior vena cava to the apex of the heart. Okay, it extends from the opening of the inferior vena cava to the apex of the heart and formed only by the left ventricle. Formed only by the right ventricle. It separates the sternocostal surface from the diaphragmatic surface. Okay. Separates the sternocostal surface from the diaphragmatic surface, and along this border you see the right marginal branch of the right coronary artery. Okay, right marginal branch or right marginal artery runs along this border, which is a branch of right coronary artery. Near to the apex, along the inferior border, near to the apex, you see a slight notch which is called as the incisura apicis cordis. Incisura means incisate near to the apex. That is why apicis of the heart, cordis. Incisura apicis cordis is a slight notch where the anterior interventricular branch cuts the inferior border. The anterior interventricular groove cuts the inferior border and transmits the anterior interventricular artery. Okay, so mainly that you will be able to see that, and not only that, the right marginal and the left marginal artery, which is seen along the left border of the heart, also is seen here, meeting point of these three arteries near to the incisura apicis cordis. Okay, that is about the inferior border of the heart. Next, coming to the left border. It is an ill-defined border. The left border is actually an ill-defined border extending from the left auricle to the apex of the heart. Okay, it is an ill-defined border extending from the left auricle to the apex of the heart. It separates the sternocostal surface from the left surface. Separates the sternocostal surface from the left surface. Mainly formed by the left auricle and the left ventricle. Left marginal artery. Left marginal artery. It is also, this border is also called as marcus obtuse. Okay. Whereas this border is actually called as marcus acute. The inferior border is actually called as marcus acute, and the left border is actually called as marcus obtuse. The left marginal artery is seen along this left border, okay, and mainly formed by the left auricle and the left ventricle. So that is about the left border of the heart. So three borders: right border, inferior border and left border. Three surfaces: sternocostal surface, diaphragmatic surface, left surface. Then you have the apex and the base. Now coming to the applied anatomy. Basically, you know, I have already discussed that, but I will just again repeat. Clinical base, which actually corresponds to the superior border. So anatomically there does not exist a superior border. In radiographs, actually we can make superior border. Surface marking, you have the superior border. Okay, so it is that border which extends from the auscultatory area on the right second costochondral junction or intercostal space to the left second intercostal space, the auscultatory area for the pulmonary trunk or the pulmonary area. So if you connect these two auscultatory areas, and that is the clinical base or corresponds to the superior border. The other borders you are able to see, that is the right border, inferior border and the left border, which are all differently colored for us to appreciate and understand. Okay. Then heart means applied anatomy. What comes to all of our mind is the angina pectoris or heart pain. We simply call it as heart attack. So angina pectoris is actually a chest pain or discomfort in the middle of the chest. Pain, discomfort, pressure in the middle of the chest is actually called as the angina pectoris. This is due to because of the insufficient blood supply. So if any part of the heart muscle or the heart tissue suffers lack of blood supply, mainly due to the obstruction of its vessels. So atherosclerotic plaque, if develops inside the vessels, then naturally it will prevent or reduce the flow of blood flow, and that is manifested as angina pectoris. There are different types of angina pectoris. One is called a stable angina pectoris. In these persons, when you do lot of physical activity, exertion, or under stress, acute or stress, then they experience this heart pain, chest pain, or it is called as angina pectoris, and the pain subsides at rest. The next is unstable angina pectoris. These persons experience chest pain even at rest. It does not disappear on its own, even it might last more than 10 minutes. Even it disappears, it will recur, and with varying amounts of time. And the pain is not only felt in the chest, it might actually be felt even at the back region, to the limbs, to the neck. It might proceed to the neck and also to the jaws. So all these symptoms indicate that there is a underlying heart disease. And what happens is, these are the symptoms that in near future there is going to be a heart attack. That is mainly the unstable angina pectoris. One is stable and unstable angina pectoris. The next type is actually microvascular angina. In those cases, actually what happens is, there is no block in the arteries, but these small vessels, the large vessels definitely has to branch out into small vessels, and they have to pierce the tissue and then supply. So these small vessels might be impervious. Blood might not enter into these small vessels. Okay, there is no any atherosclerotic plane, but these small vessels are impervious. They might not conduct the blood. So that is called as microvascular angina. Then you have something called as the broken heart syndrome, mostly seen in women. Women experience, usually women, not always, usually women experience this because if they undergo a trauma, mental trauma or something, if they lose their loved ones, lovable ones, their partner or children or anybody they adore very much, or due to any sad incidents, they might experience heart pain. What happens in those cases? A part of the heart alone expands abnormally, while the remaining part of the heart beats in a normal fashion. Okay, that is called as broken heart syndrome. This is due to sudden surge of the hormones. Okay, emotional response, due to some emotional response, sudden surge of hormones, they might experience this, and it is completely treatable. Okay, but if it is left untreated and if they are again experiencing again and again, it might lead to further complications. So that is called as the broken heart syndrome. So these are some of the applied aspects. We will be discussing more of this as we deal with the chambers and the blood supply of the heart one by one in the succeeding classes. So thank you very much for your patient listening. We will meet again in one more topic.